Yeah, good evening, everyone. Good evening, respected Kamal Sharma sir, Dr. Makad sir, and eminent panelist. Sir, you were indeed our teacher, and you inspired us throughout our college journey as a professor. The case shared today is ACS PCI 7 days back and cardiac rehabilitation. 39-year-old male had presented with ACS for which he underwent successful PCI to RCA 7 days back. He had dyslipidemia. He is on Rosuvastatin and GDMT, and scientific and only supervised cardiac rehabilitation is the most time-tested and proven methodology for the ACS PCI to RCA 7 days back. Most important is keeping his acuteness and fragility of the whole condition in mind. Cardiac rehabilitation is the customized outpatient program of exercise and education. The program is designed to help improve the health and recover from heart attack, other forms of heart disease or surgery. Over a period of years, it has evolved from simple physical activity to a complete multidisciplinary approach where cardiologists, physicians, physiotherapists, nutritionists, exercise physiologists, psychologists, and yoga, entire team of multidisciplinary approach is involved in the overall care of rehabilitation. And in a particular case, and otherwise, we would categorically divide into three parts. One is the primary prevention for a person having hypertension, diabetes, dyslipidemia, or a secondary prevention post myocardial, conservatively treated myocardial infarction, or PTCA, or CABG, or any other cardiac procedures. And third condition, which is now talked a lot, rehabilitation, where before undergoing any major surgery or major medical condition, person is prepared for the cardiac rehabilitation purpose. In most current guidelines of cardiovascular societies worldwide, cardiac rehabilitation is a class 1 recommendation. Clinical trials have proven the strategies for the detection, rehabilitation, and modification factors which can slow, stabilize, or even modestly reverse the progression of atherosclerosis and reduce the risk of cardiovascular events. Cardiac rehabilitation programs have become now integral part of standard of care in the modern cardiology. In recent time, the development of structured and supervised cardiac rehabilitation program grew out of concerns mainly about the safety of unsupervised exercise in patients with acute coronary events. If we recall the journey of incidents that we have seen over a period of last 1 or 2 years, we have seen so many celebrities, Siddharth where Suryavanshi at 46 collapsed in the gym, Sagar Pandey, 50-year male, Raju Srivastav, Punit Rajkumar at 46 was working out in the gym in the Bangalore, and he expired, and many such known or unknown stories we have come across. Cardiac rehabilitation with supervision and programmed exercise is utmost importance to reduce the mortality rate, and it will consist of a journey where there will be a thorough physical assessment, cardiopulmonary fitness testing, prescription of exercise training, monitoring the vitals during exercise, emotional support, education about lifestyle changes like healthy diet, maintaining healthy lifestyle, quit smoking, etc. So technically it will be divided into three phases. One is inpatient, outpatient, and then long-term maintenance plan. Consistent, four things will be major classification: exercise, nutrition, stress management, and lifestyle modification. But overall, assessment will play a vital role before beginning any program, and then there will be problem-oriented programs and solutions like blood pressure management, dyslipidemia management, diabetic management, lifestyle, tobacco cessation. Most important of all, here we are talking of physical activity and exercise planning along with nutrition planning. So research says that scientific data clearly establishes the exercise training results in improvement in SI's tolerance. Appropriately prescribed and conducted exercise training therefore is a key component of cardiac rehabilitation. Mayers et al. 2002 showed that an improvement of 1 MET in functional capacity imparts 12% reduction in all-cause mortality. More recently, Jolie et al. In 2011 showed the abnormal heart rate recovery, which is predicted mortality, can be normalized with exercise training with an improvement in mortality. Now, in specific cases like heart attack, congenital heart disease, post-PTCA, post-bypass, post-transplants, we would recommend supervised cardiac rehabilitation for the initial time, and then it can be managed independently in the long term. And these are the contraindication: unstable angina, arrhythmias, pulmonary hypertension, presence of thrombus, or severe obstructive cardiomyopathies, which was thought as many of the celebrities who died at young age in working out the panel of medical people across the country have cited one of the reasons as hypertrophic obstructive cardiomyopathy. They did vigorous resistance training, and they were not aware about probably on their normal systolic or diastolic pressure also, and their resistance training went beyond imagination without any possible monitoring patterns. So our goal for a particular patient and otherwise will be to improve heart functioning with safety, to regain strength, endurance with safety, to prevent condition from worsening, to improve health and quality of life, and to reduce risk for future heart problems. So most of the time when we talk of cardiac rehabilitation, heart rate or Carbon's formula or maximum heart rate or target heart rate is one of the gold standard method found it across the situations and across the different settings. But I would say that heart rate is only half the story. We will have to really look into many other parameters: heart rate, heart rhythm, specifically heart strain, like how much amount of oxygen deprivation is actually happening at the cardiac level, even if patient is physically feeling very comfortable, or heart rate variability or breathing pattern, rightly termed breathing rate, respiratory rate. Actually speaking, respiratory rate will be the ideal guideline, because actual muscular activation and physical exertion will be perceived rightly, or rate of perceived exertion will be correlated rightly in correlation with the respiratory rate, because heart rate is variable. Many times what will happen, situation like temperature, situation like people's presence, humidity, environment, anxiety, stress will bring change in the heart rate, whereas respiratory rate will, or breathing pattern will be directly correlated with the actual rate of perceived exertion. So in a particular case, and otherwise in this starting phase where it's considered as a sensitive phase, we must focus on particular parameters like heart rate, heart strain, heart rate variability, and there can be double checks also. For example, in the system that we use nowadays, where single beeps at a particular heart rate or a double beep at a heart strain where at 0.18 MV or 0.15 MV or 0.20 MV, wherever we set the parameter. So even if a cardiopulmonary physiotherapist or a medical officer who is monitoring the case progression is slightly unaware of the situation, but artificial intelligence and current technology has provided us with the database where they are able to detect the incident of anything which is not sound for a particular person at that particular time. So for this particular male, body weight, height, body mass index will be assessed. Then his risk factors, biochemistry finding, as we already knew, dyslipidemia, echo findings, past history of physical activity. What was his physical activity before this episode? Heart rate, blood pressure, SpO2 at rest, during and post exercise, ECG at rest, during and post exercise, and breathing rate correlated with rate of perceived exertion. And then in terms of functional capacity measurement, we will be talking of cardiopulmonary exercise test evaluation following different criteria, 6-minute walk test or shuttle walk test or various other submaximal functional protocols which are to assess exercise intensity, muscle strength testing, respiratory muscle testing, or musculoskeletal assessment. And then on the basis of that FITT principle, frequency, intensity, time, type, entire classification of exercise will be made for him. And today, resistance training should also be given importance in a particular age group, but keeping in mind the response of heart rate, blood pressure, and other variables while the person is undergoing resistance training. But low weight or moderate weight resistance training will in long term help to benefit patients in daily activity performance. Otherwise, variety of material are used for endurance and resistance training: treadmill, stepper, weight, rowers, elliptical trainer, exercise bike, dumbbells. And beneficial effects are numerous, as already noted: improvement in autonomic balance, sympathetic system and parasympathetic system balancing, decrease inflammation, inflammatory cytokines, improvement in insulin resistance, decrease adiposity, improvement in cardiopulmonary functional capacity, decrease dyspnea, decrease resting heart rate. And warm up and cool down is very essential. Strength training, endurance, cardiopulmonary condition will play a critical role after warm up and before cool down. Interval training can also be performed depending upon the capacity of the person. Active interval and rest interval can be planned, where initially active interval is more and rest interval is less, but down the line rest interval will be reduced, and we will be taking this particular person on the continuous training also. Along with breathing exercise, breathe hold should be avoided, stretching, yoga, pranayam, nutrition, etc. We use various systems. One of the system we are using nowadays is wireless ECG monitoring system in the setup, where there are sensors across the cardiopulmonary rehab area, and patient wears straps. There is a pickup technology which picks up the waves with Bluetooth and various other parameters, and then this can be monitored. And this also has artificial intelligence component where certain alarms are given inside the situation, and depending on the age group, safety plan can be done. So the benefit of supervised cardiac rehabilitation include mortality reduction, symptom reduction in smoking, improved exercise tolerance, risk factor modification, and increase in psychological well-being and quality of life. But unfortunately, cardiac rehabilitation remains considerably underutilized, mainly because of referral problems and maybe poor enrollment and maybe poor awareness, which has to be spread by us. Therefore, development and implementation, supervision of safe and effective person-based exercise plan are needed to maximize the benefit to health and quality of life with early and appropriate vocational and recreational activities. Thank you.
Good evening, chairpersons, moderators, and my fellow speakers. At the outset, I would like to thank Dr. Kamal Sharma for giving me the opportunity to share my views with this August gathering. And I intend to highlight the role of yoga and meditation in post-PCI cardiac rehabilitation. Here we have a young male who had acute coronary syndrome and he underwent cardiac intervention. His lipid profile is deranged and he is put on optimal medical management. The important thing is he has history of COVID-19 a year back. He requires cardiac rehabilitation so as to reduce the risk of recurrence and improve the quality of life. The question is, which is the best suited lifestyle modification therapy for him? Is it supervised exercise, yoga and meditation, or home-based therapy? Cardiac rehabilitation includes all three aspects: exercise training, lifestyle modification, and psychological intervention, so as to reduce stress, reduce anxiety, and keep the person or the patient motivated so as to pursue exercise training as well as lifestyle modification. In this post-COVID scenario, as has been highlighted by the previous speaker, is physical exercise actually safe? Because we have seen that there is an increase in the incidence of sudden cardiac death, even in those patients, even in those persons who are physically very active and who are athletes. COVID virus not only has a direct viral damage, but it also has a immune system activation, which can lead to post-acute sequelae of COVID, which is also known as long hauler. And patient can present with potential symptoms long after COVID when the initial part is over, and they can present with tachycardia, palpitation, chest pain, dyspnea on exhaustion, and as well as exercise intolerance. So in such a patient, even if we advise them exercise, they are not able to tolerate it. And long-term consequence of COVID-19 has shown that myocarditis is prevalent, and fibrosis, myocardial edema, ongoing inflammation is present, thrombogenesis is there, systemic embolism is present, and patient can have heart failure, and then they can also have a new onset arrhythmia, which can lead to sudden cardiac death or some cardiac episodes. Looking at the cardiovascular involvement of COVID-19, it can be in the form of venous thromboembolism, arrhythmia, pericarditis, Charcot's tubercardiomyopathy, myocarditis, heart failure, and myocardial injury. This was published, this expert consensus decision pathway was published in JAC May 2022, which highlighted the importance of return to play, how we should bring the patient back to their physical activity, normal patient as well as athletes. How should we go about it? And they have emphasized that regimented return to play should be emphasized in all individuals with prior COVID-19, so that cardiac monitoring of the symptoms and cardiopulmonary symptoms can be done. And those patients who have myocarditis, long-term abstinence is advised. And as has been highlighted by the previous speaker, individualized training concept for post-COVID-19 patient has been brought out. But I would like to bring to the notice of the panelists and the chairpersons, and I would like to quote from this article. through all stages of COVID-19 pandemic and beyond, risk of adverse cardiovascular outcome during athletics will persist despite best CV screening practices, and emergency action planning initiative represents our best strategy to save lives. So even though we analyze the patient and give them the right supervised, individualized protocol, still the risk of sudden cardiac event will be there. So in such a scenario, is yoga and meditation best suited for post-COVID patients? I would say yes, because it shifts the focus from illness to wellness, and it produces an integration of spirit, mind, and body. It integrates breathing pattern. It brings the focus back to now. Breath becomes steady. The body is still, and all aspects of human psycho and physiological functioning is improved. It avoids any violent, jerky movement. It is non-competitive, and it is done with breath consciousness, and it is instrumental to bring physical, mental, and spiritual well-being in a patient, especially in a post-COVID scenario where post-traumatic stress syndrome has been brought into light. Positive psychological well-being is very important for cardiovascular health. This we all know. And stress increases the episodes of a cardiovascular event. So yoga reduces stress by breath control and meditation. Physical fitness is improved by yogic postures, and lifestyle changes is also brought by self-restraint. By stimulation of parasympathetic activation, it increases glucose tolerance, insulin sensitivity, which is effective in obesity and diabetes. It also reduces oxidative stress, and it reduces the risk of atherosclerosis, hypertension, and cardiovascular death. Coming to the benefits of pranayama, it improves respiratory function, immunity improves, inflammation decreases, and psychological stress also reduces. So in the nutshell, yoga and meditation brings about physical wellness, mental wellness, as well as emotional well-being. So all the core components of cardiac rehabilitation, like exercise training, nutritional counseling, weight management, blood pressure management, lipid management, diabetes management, this was brought out by Dr. Alap also, that we want complete cardiac rehabilitation. This all can be done by yoga and meditation. It is a one-stop arrangement for everything that we want for cardiac rehabilitation. Coming to the review of literature, this is an article which was published in Health, Sport and Rehabilitation 2022, where it showed that yoga improves physical and cardiopulmonary conditioning and attenuates systemic pro-inflammatory and pro-thrombotic disorders. Again, coming to this article, Yoga for COVID-19, an ancient practice for a new condition. This was again a literature review, and it showed that yoga is a psychosomatic approach that increases physical, mental, emotional, and spiritual strength. This was an editorial which was published in International Journal of Yoga 2020, and it showed that yoga causes significant alpha brainwave activation in frontal lobe and increase in natural killer cells, which points to a calm mind as well as better cellular immunity. This was a case report which showed that integrated yoga and naturotherapy brings about cardiovascular and mental well-being. Again, this was a randomized controlled trial which highlighted the importance of yoga and naturotherapy. This was a review article which I have taken from, this was done in Indian Institute of Public Health, Gandhinagar, Gujarat, and it again showed that yoga is a positive long-term, yoga brings about positive long-term impact on overall physical and psychological well-being and quality of life. So I would strongly recommend yoga and meditation as the best and holistic cardiac rehabilitation strategy for my patient, because there is no incidence of exercise-induced adverse event, and it brings about complete physical and mental well-being. When we get everything through yoga and meditation, why should we look for any other modality? Thank you so much for your patient listening.
Good evening everyone, and respected doctors. Today we will discuss physiotherapist guide home-based cardiac rehab. in the setting of post-PCI ACS. So I want to emphasize on home-based physiotherapy more because I strongly believe that all we are discussing right now are the lifestyle changes which has become patient's lifelong habit. Then it is going to benefit patient the most than by home-based physiotherapy guided exercise. I can assure the patient will learn them in his familiar environment and at his home, and he is surely going to include that in his lifestyle. So there are many more benefits at home-based guided rehabilitation. So we can modify lifestyle changes like diet, weight control, flexibility, strength, psychological support with home-based guided rehab. So the phase we are around three phases available. So first phase we are going with first optimal phase of cardiac rehab, in which we include breathing exercise. So there are 5 types of breathing exercise. So normal breathing exercise, then diaphragmatic breathing exercise, then pursed lip breathing exercise, then modify mobility breathing exercise, a kind of segmental breathing exercise, and hold breathing exercise. So we will be monitoring him with this exercise and assess with vitals. If patient is compliant with breathing exercise in 14 days, then we will upgrade him to next phase, which will last for 15 to 45 days. Then after we have modification around phase level 2. This is a phase 2 workout. So in which we include moderate walking, 6 to 10 minute walk on ground surface, and going downstairs, not upstairs, going downstairs 10 to 12 steps per day, and start with also spirometer exercise. And if patient compliant with this stage, then we will upgrade him for the next phase. And then the next phase. So this is a upgrade phase. Phase 1 is a low level, phase 2 is a moderate level, and then phase 3 is a graduation. Like in after 1.5 months, we will start with medium intensity circuit exercise. In this, we will focus on cardio, strength, and stretching circuit exercise, and also start with aerobic exercise like walking, jogging, cycling, and circuit exercise, and also interval training exercise at home. Then why? So patient will adhere more to home-based rehab, and rehab and therapy will be more subjective and customized. And so in a nutshell, physiotherapists guide home-based cardiac rehab will help us in secondary prevention of ACS morbidity and mortality both. So thank you so much.